Welcome back to another episode of Everything is Public Health. We have with your wonderful host, Dr. Murray, co-host Mr. Murray, and our super producer, Intellectual Dre. Today we're going to be talking about racism and health outcomes, and we have a wonderful, amazing guest, Dr. Camara Jones. Dr. Jones, tell us a little bit about yourself.
Hi, thanks. I am a family physician, so a family doctor, but I don't practice anymore. I'm also a public health researcher and epidemiologist. And mostly what I do these days is help people understand that racism exists. And so I call myself an anti-racism thought leader and activist. I am currently living in Atlanta, Georgia, but my role right now for this year is as a 2021-2022 UCSF presidential chair at the University of California, San Francisco. So you might ask, why am I in Atlanta? COVID. But I am going to go out to San Francisco in a little bit.
All right.
Yeah.
Doc Murray, what's going on?
Nothing much. Welcome, Camara. I'm so glad you could join us tonight. Everything's fine with me. I'm doing well. I'm looking forward to tonight's conversation. We're going to be going to 7:30 tonight, and we're going to be talking about racism and its impact on health.
I think we're all looking forward to it. You know, I definitely think people should check us out on YouTube after this show is over and watch it 2-3 times. And I will say this, if you get emotional or you get triggered or anything, you just have to deal with it, because tonight we're going to speak the truth. Doc Murray, kick us off. What is racism? Talk to us.
Well, Kamara's really the person. So, you know, racism is a, we all know in our bones what racism is. And I think Dr. Jones, Camara has made such a great contribution in taking this complicated and nuanced subject and translating it for our rather slow doctors specifically could deal with the concept. So she has a simple definition that I'm going to let her say, but let me just say this, that in sociology and anthropology and history and economics, all these disciplines contribute to our very nuanced understanding of racism. And the things I like about Camara's definition, which I'm going to let her talk about, is that it is an international definition. It's not a definition that's only bimodal, you know, white and black in the United States. It really is an approach and a framework that all of us in health, public health, medicine, nursing should think about. So let me ask you, Camara, to explain your definition.
I surely will. And I think, Linda Ray, thank you for asking me. I'm going to say my definition in one sentence, then I'm going to circle back and lift up the most important things that people sometimes don't understand about racism. So racism is a system of structuring opportunity and assigning value based on the social interpretation of how we look, which is what people call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. So that was a pretty long sentence, but let me start. And I think there's like 4 or 5 things I want to lift up. The first is that racism is a system. So it's not an individual character flaw or personal moral failing or even psychiatric illness, like some people have suggested, even though for sure it can show up in those ways. But in its essence, racism is a system of power and of doing what it can do. It does 2 things. It structures opportunity and it assigns value. Now, on what basis is racism structuring opportunity and assigning value? Based on so-called race, which is the social interpretation of how we look in this race-conscious society. So I really want to go deep with you, like that race is not biology, but we're going to put that on the side because I used to do a 1-hour lecture on what is race. Okay, so this so-called race, this on-the-street classification, right, that we get assigned and that we assign others without asking, excuse me, how do you self-identify even? Or excuse me, where were you born? Where were your parents born? Or excuse me, may I have a little bit of your blood? I have a genetic hypothesis. This kind of on-the-street race is the same race that a police officer notices, or a taxi driver, or a judge in a courtroom, or a teacher in a classroom. So anyway, that's what racism is operating on, is this social classification of one to the other, this street race. But the last thing I want to say is there are 3 impacts. Now, a lot of this people in this country are in what I call staunch racism denial, and I would love to go deep on that too. But when people do recognize in this country, we who are living with the most adverse impacts of racism know that racism is real and is operating day to day. But when other people recognize that racism is alive and well, they kind of say, oh, okay, yeah, maybe it is disadvantaging some individuals and communities. But when you start talking about the fact that every unfair disadvantage has its reciprocal unfair advantage, then they're like, oh, don't go there. You might make white people uncomfortable, right? But every unfair disadvantage does have its reciprocal unfair advantage. And for people who don't want to recognize that, I used to, because I do a lot of storytelling, I used to say, oh, well, shake it off, shake off the discomfort, stay with you, I'll tell you more stories. I don't say that anymore. I say, if you feel uncomfortable, you need to lean in to that discomfort, right? And we could talk about how people lean in. But the third impact of racism, that it's sapping the strength of the whole society through the waste of human resources, is actually an impact that a lot of us miss, that it's affecting all of the whole society badly, even though some people are profiting from racism, right? But that is perhaps the thing that we need more stories about in our media. So, newspapers, TV, radio, all of it. This is perhaps what we need to do more research on, because we need more people, all of us, having a strong sense of urgency to dismantle this system and put in its place a system in which all people can know and develop to their full potentials, so that we stop just being like blinders on about the genius in our children, right? And we aren't investing fully in their excellent public education, that we stop having these blinders that make us miss the fact that we are complacent with how we are warehousing so many of our Black and brown and Indigenous men and women in the prison system, as if that didn't represent some kind of loss of human potential. We have to stop these blinders that don't value all of us, that allow these systems to keep operating. We need to explode all of that, because it's not only hurting those of us whose opportunity has been constrained, it actually, even though they don't recognize it, it's hurting the whole society. What do you think? Oh, Linda
Dr.
Ray.
Murray, you're muted.
I'm sorry. Trying to follow Andre's
Mr. Murray.
instructions.
Wait, I want to ask you, Mr. Murray, should I call Dr. Murray Dr. Murray?
Nah, you call it what you call on the street.
Okay.
We good.
Okay.
Yeah, we family on here.
Okay, because I know her as Linda Ray. She knows me as Camara. So
So
Yeah,
I wanted to make a couple of points. I think this definition which Camara has really spent a lot of time trying to put out there in the health sphere, in the public health and medical sphere, which is really needed. I wanted to add a couple of things to that, which I think some of our historians and other people keep in mind. So one is, even in the United States, our definitions of race, which is a social category, as Camara has said, have changed over historical time. So let me give you some examples. When I was a younger, I'm 73. So when I was young, multiracial did not exist. Well, obviously it existed, but that's a term that did not exist. The United States has what we call a one-drop rule. So in the United States, it was like one drop and you're black. It was very simple. So let me give you some historical extremes of that. Walter White, who is a major civil rights activist, he was the leader of the NAACP for many, many years, played a critical role in the history of Black people. This is Black History Month. Walter White was blonde hair, blue eyes. And he actually used this to his advantage. He was one of the investigators, especially when he was younger, before he got widely known, for the NAACP. And he was able to go where white folks were and document what they did. So it's not just that he could pay. Of his 8 grandparents, right? That's how many you have, right? 1 was black, okay? But in the United States, 1 drop and you're black, and his family chose to live as black people. And like I said, he was a leader of the NAACP, etc. So that's one extreme. I'm trying to get the right Supreme Court case. Hopefully Dre won't kill me. It's not Plessy versus Ferguson. It's the one, I'm going to forget the one it was, but there was an important Supreme Court case that had to do with should we have segregated trains in the South? So the railroad companies, they didn't want.
That was Plessy.
Was it Plessy? Okay, good. So Plessy could pass. I forgot what percent he was. But the point I'm trying to make is the railroad companies found Plessy, had him ride the train, because they wanted the Supreme Court to say we don't have to have this segregation on the trains. Because what that meant for the train company is, if you're in New York State, you can have 1 car, but then when you get to the South, you pass the Mason-Dixon line, you got to have 2 cars, because you got to have a separate car for blacks and a separate car for whites. But the Supreme Court said they didn't care. Plessy was black, even though if I showed you pictures of him, which I do in my classes, he would be white. Camara often talks about, and this is true, internationally for Afro people of African descent, internationally that definition changes,
right?
And so who's black so Trevor Noah, for example, is considered colored in South Africa. Now, in the United States, in New York City, when he goes out of his house, he's black. But in South Africa, under apartheid, he was considered colored. So I think
he might go to Brazil and be considered white.
He would be, because he has money
in some parts of Brazil.
Right.
Money, and also in like Bahia and all, even with his appearance. Right.
So one thing is to understand this historical definitions change. Another thing, which again, this is Black History Month, but I want to say this quite clearly. We tend, because Africans are on the bottom of this racial hierarchy in most places in the world and throughout most of history. So I want to acknowledge that. But we tend to think in America, because we don't learn American history, that we're the only ones that experience racism. So again, I want to make something clear. It helps if you go back and read the original language of these historians. So if you go back and read what those white people were saying about Native Americans, they didn't consider them human. The Supreme Court didn't consider Native Americans human beings until 1924. Think about that. Okay.
And may I jump in on this?
Yeah.
Because in Australia, so we think we had it bad. We think that South Africa had it bad, and we still do, and they still do. But in Australia, I'm going to say, even in the 1950s, maybe more recently than that, white Australians would go Aboriginal hunting like they would go kangaroo hunting. I mean, talk about not thinking that the Aboriginal people were fully human. They implemented that in that way. Some people say, well, they're hunting black folks in this country right now. And I would say, that's true. So you're right about the depth of this racialization and black folks at the bottom. Aboriginal people, if an Aboriginal person came here to the US, they would be black, even though they are long from Africa. There's a whole different gene pool and a whole different history.
And they got good hair. In our culture, they would have good hair. That's the only way you can tell the difference.
Anyway, so Linda Ray, I interrupted you, but
that's all right. I think that's a great example. The example I was going to use that's current today is people don't understand. First of all, let me be clear. White people couldn't tell anybody apart. So they had the Chinese Exclusion Act. That's in the 1880s. They wanted the Chinese to come here and work them on the railroads and in mining in the western part of our country. We don't talk about this either. There was a trans-Pacific slave trade. Asians, Chinese, Filipinos, other Asians were brought by the Portuguese and Spanish predominantly to the Western Hemisphere as slaves. It's a different history, but the point is to remember that. But the largest mass lynching that occurred in the United States history occurred in Los Angeles with Chinese. And so today, when we have these little myths of Asian doing well, we mix up all the Asian groups. There's 250 different groups, cultures, languages among people from the continent of Asia, but we just lump them all together. So then we miss some of these differences. We'll talk, I hope, later about people getting to med school, but I'm gonna tell you, Southeast Asians, Vietnamese, Cambodian, they have lower rates and lower application rates to medical school than Blacks, for example. So it's important for us to understand. Oh, and the last thing I want to say, I shouldn't forget this is critical. When the United States conquered the northern part of Mexico, otherwise known as California, Arizona, that kind of, so there was a treaty that ended that war, and built into the treaty was the language that said anybody living north of the border are automatic American citizens. That was in the treaty. Okay. But during Reconstruction after the Civil War, same time when there's expansion west to those western states, Mexicans and Mexican Americans, because they were all American citizens, so they were lynched from trees at the same proportion as Blacks. Okay? History that's not made clear. And go ahead.
No, well, this history is important for us to know and for everybody to know. And all this anti-critical race theory stuff that's going across the country, they don't want the people who want to pretend that the way that wealth is distributed and all is just a happenstance and that their advantage is normal. They're the ones who are denying racism. I'm thinking a lot these days, like top of mind, at the edge of my thinking is our need to confront racism denial in addition to all the other things that we're doing about racism. They don't want any of us to know this history, right? And so what are we supposed to do, Linda Ray? I know in your class, you're teaching the history. Right now, you're teaching the history, through this podcast. But what are we supposed to do to teach the history? We need to go back to Saturday schools, or
absolutely. And we also need, and those of us that are can already read, we need to read more. Let me bring this up to a more current time period in my lifetime. Even though they were considered American citizens, Texas, California had segregated schools. So if you look dark enough, now if you look white as a Mexican, it probably didn't matter. But if you look dark enough or you came from a predominantly Mexican neighborhood, they had segregated schools. And the Brown versus Board of Education, in famous case that went to the Supreme Court to desegregate education, early cases, they joined some cases from Hispanic communities with Black communities, because these cases go up in the lower courts to present the whole package of cases. The last thing I want to say here before I get back to this interesting thing of how do we teach this stuff, two things. One is, which again, I consider this, I am embarrassed by this. I will say this has gotten better, but for decades I would be at meetings. Sometimes it'd be historians, sometimes it'd be doctors, sometimes it'd be PhDs. I'd be in an audience of Black people because you don't want to embarrass people. And I would ask them, where do most African Americans live? People of African descent with a slave history. And then I would even ask them, when people are mumbling the South, who and what language do they speak?
Right.
For decades, no one got the right answer. So this is basic information. That's basic history. Transatlantic slave trade. There's a debate about how many people were stolen. It doesn't really matter. 12 million, 20 million, doesn't matter. What we know is that only about 4%, under 500, came, if you use the 12 million figure, came to the British colonies in the United States and are part of our history. That means 95% went to the rest of the hemisphere, the Caribbean, Mexico, South America. And so when we get into this little game about, blacks versus Latinx, it's like we don't understand our history, because most of our people, most of our direct first cousins are in the rest of the hemisphere, and they speak Portuguese and Spanish.
Right.
So the last thing I want to say is Nancy Lopez, who's a good sister. Nancy Lopez, a Latinx, a Latina sister. She argues, when we do our research, we're going to be talking about this in a minute, when we look at racism and race in this country, she says, and especially for new immigrants, because new immigrants come here, they think they're Bulgarian or Irish, or they're not used to the American pathology. So she says what we should be asking people. It's polite to ask people, how do you identify? Got no problem. But she said what we need to ask people is, what is your street race? She said when they ask you what is that, they say, when you're walking down the street, what do other people think you are?
Well, we developed a measure of that. So we call it socially assigned race. But back at the CDC, when I was at CDC, we developed a 6-question, we call it Reactions to Race module, where the first question was, how do other people usually classify you in this country? With the possible responses at that time in 2002 being white, black or African American, Hispanic or Latino, Asian, Native Hawaiian or other Pacific Islander, American Indian or Alaska Native, or some other group. So we at that time, of course, on this survey that the states do, the Behavioral Risk Factor Surveillance Survey, they already asked self-identified race ethnicity as 2 separate questions. We were making a distinction between self-identified race or ethnicity or race ethnicity and socially assigned race, right? And also not making an artificial distinction between so-called Hispanic or Latino as something else, ethnicity, and the others as race. So we have data from 29 jurisdictions, so 27 states, the District of Columbia, and Palau, over 42 different years and survey states that explore that. We published a paper in 2008. We wanted to call it the health benefits of living white, but we couldn't get it out of CDC like that. So it's called using socially assigned race to probe white advantages in health status. And what we looked at, first of all, you won't be surprised to know that people who are usually classified by others as white reported better health. The outcome we used was the question, how would you say in general your health is? Excellent, very good, good, fair, or poor. That question has been shown to be a great question at predicting like real health. These are telephone surveys. So we didn't have people's blood pressures or, body weight or anything like that. We looked at excellent or very good health as our outcome. People who were usually classified by others as white, you would not be surprised, reported significantly more excellent or very good health, significantly less fair or poor health than people who were usually classified by others as Black or Hispanic or American Indian or Alaska Native. We had other groups too. I want to drill deep on this. So that was okay. But then we also, when we started comparing the self-identified race that we learned to put on forms and this socially assigned race, which they're newly calling street race, there were, for people who self-identified as white, it was about 97% usually classified by others as white. People who self-identified as Black, about 94% usually classified by others as Black. For people who self-identified, are you Hispanic or Latino? Yes. No matter what they then answer for their race question, their race ethnicity gets Hispanic, because we do this, non-Hispanic white, non-Hispanic Black, Hispanic, right? We do that. Those people, 63% usually classified by others as Hispanic, 27% usually classified by others as white. This was the first entree into understanding when we started comparing their responses that if you were self-identifying as Hispanic and looked Hispanic, your health was a lot worse than those who self-identified as Hispanic, looked white, and it didn't matter if you self-identified as Hispanic and looked white or you self-identified as white and looked white. There was no evidence of difference in your health. So then we said, are there any other groups where we could look at this? So then we had American Indian or Alaska Native. So they had been asked, are you Hispanic or Latino? They said no. Which one or more race? They picked only one, American Indian or Alaska Native. So not me with my Cherokee great-grandmother or you or any of us, right? Okay. One. For those people, 46% usually classified by others as Indian, but some huge amount, I don't remember, 30% usually classified by others as white. It didn't matter if you said, I'm Indian. If other people thought you were Indian, your health was a lot worse than if other people thought you were white, significantly worse. And it didn't matter if you said, I'm Indian and looked white, or said, I'm white and looked white. Again, you couldn't tell the difference in the health outcome. Is there another group? Well, we had those people. Are you Hispanic, Latino? No. What race? What one or more race? And they picked more than one race. So they were multiracial. 22% of them usually classified by others as Black. I'm going to say 60% usually classified by others as white. You know, there are other groups there too. And that even more extreme, if you were multiracial and looked Black compared to white, huge difference, right? Both of you saying you're multiracial, didn't matter if you said I'm multiracial or white, no evidence of difference. So what I am saying to you is, yes, people who are looking white in this country are advantaged by their on the street thing, ability to pass. Even Walter White, who was living, you know, like identifying as Black, but he had all of the advantages. And I'm going to tell you, he probably lived to a ripe old age unless somebody killed him, but because he was living white, right? So that's true even among people who self-identify as some other group. We didn't have enough. Yeah. Okay, go on.
No, I'm going to say, let's do some teaching here. So what journal is this article in so people can look it up?
So it is in Ethnicity and Disease in 2008. I am the first author of, I think there were 7 of us. So it's Jones, CP, Ethnicity and Disease, 2008. And it's called Using Socially Assigned Race to Probe White Advantages in Health Status. So I did hear this terminology. I know Nancy, I love Nancy Lopez. I did just recently hear that they're calling this street race. In some of my presentations, I call it the on the street race. And, you know, you heard me say it without the benefit of somebody asking, how do you self-identify, or where were you born? Where were your parents born? Or may I have some blood? So I am glad that it's getting out there like that, because socially assigned race, maybe people can't really figure out what that is, but you can go and research yourself. If you go to the CDC's website, if you go to www.cdc.gov/BRFSS, which stands for Behavioral Risk Factor Surveillance System. And then if you're savvy, you go into all of that, you can get the data yourself. I could send you, Linda Ray, so then you could tell people like which years and which states used it and which years and stuff like that. But those data are public access data.
Mm-hmm. So again, so those of you, especially those of you that are working in public health and trying to do some research, these are some things to think about in terms of how you think about your research. Don't do, I'm going to say something that's not polite, but don't do your research the way most of your faculty teach you to do research. You know, put some color in it and really be thoughtful and critical about how we do these categories. This is an important research that came out. I remember there was some little trouble getting it out, but in any case, you have to remember that a lot of the publications didn't want to publish on this. Like, it's not just the CDC didn't want the title. If you look at any of our studies of what articles get published, there were many, 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 many decades where you were not allowed to talk about racism in a medical or public health journal.
Why is that? Why is that? It's part of our culture.
Well, racism denial. See, so now why is it? Because if you say racism, first of all, then that internalized sense of entitlement that many white people walking around with, this internalized racism, demands that you're so-called normal, that what you're entitled to is fair and all like that. So this internalized sense of entitlement demands that you deny the existence of racism, that you deny that there's an unfair system going on. So there's that element. But even people who are so-called woke, you know, who are in institutions that are woke, in states that are woke, right? There comes a point for many people where they might say, well, I guess there's no room for white men anymore at this institution, where they no longer feel comfortable, right? And I have come, some more of this edge of my thinking thing is, I have come to recognize that given the current status quo, there is a tension, a polar tension between those who value comfort and those who value social justice. And those who value comfort are like people in one of the allegories that I tell, my dual reality, a restaurant saga. It's like people sitting up inside a restaurant, born inside a restaurant, sitting up inside the restaurant at the table of opportunity eating and looking up and seeing a sign that says open. And not recognizing that that sign that declares open to them is a two-sided sign that is declaring closed to others. It is, so these people in this restaurant, if they think about other people at all, probably just say, well, why aren't those people just, you know, why don't they just come on in and sit down and eat? But most of the time, they don't even wonder why other people aren't coming in the restaurant, right? Because they would prefer that they don't. They think other people come in and eat up all the food. They don't even ask, how did the food get brought to the back of the restaurant, the kitchen? How did it get cooked? Like they don't wonder about these things. They're comfortable with the status quo. Those who value social justice, on the other hand, know two things, that there's a two-sided sign going on. Many of us know that because we were born looking at the closed sign, but could look through the window and see people inside eating. But the other thing that but let me just say this before I get in too much trouble. You don't have to be, you could be born inside the restaurant, but you need to be the one who's wondering, why aren't other people coming in? You need to be the one wondering, why is this door staying closed? You need to be the one wondering, what are they saying outside? Black Lives Matter. Why are they saying Black Lives Matter? And then you go and you open the door and look. Or you need to be the one who says, I heard that there's a two-sided sign going on. And rather than saying, we can't go anywhere near the sign to even just touch it, to look at it. That is, we can't talk about history. We can't talk about racism, all that. You might be the one, if you were born inside the restaurant, who actually went out and says something. So I'm not saying that it's, you know, that all people who are born inside the restaurant value comfort. There's some people who are born outside. Once they get in the restaurant, want to stay up in there and don't want to let other people know how to get in, right? Okay, so I'm not saying there's a divide. But what I am saying is that the people who value social justice know two things, that there's a two-sided sign and that two-sided sign is sapping the strength of the whole society through the waste of human resources. So I think that people don't want, I mean, we submitted this paper to the New England Journal of Medicine back, you know, in 2007, 2008. We were told that the New England Journal of Medicine doesn't publish BRFSS data, which is a lie, but we were told that. So then we submitted it to JAMA, the Journal of the American Medical Association, and told the same thing, that they don't publish BRFSS data. So then we went to Ethnicity and Disease, which, you know, set up by some of our people and publishes our stuff. That paper almost won CDC's top science award in that year. The reason it didn't, I'm not even supposed to know that, but we were the last two, right? And us and the winner. And the reason it didn't win is probably because somebody asked me a question about it. They didn't really understand about this socially assigned race. And if I had seen that email in time, maybe I could have explained it to them and then maybe we would have. But it was also recognized by CDC, even in Ethnicity and Disease, which is not, you know, the top journal. It was recognized for the power it had. I thought we should have been on Nightline at the time, Ted Koppel, right? I thought this should have gotten big play and it never did. But anyway, it's like serious science. So I do want you guys to go look it up. And thank you, Linda Ray, for talking about where we publish stuff and the barriers we have and why can't we say
it's
racist.
really important. And I have a more modern story that's very distressful. I think you know Michelle Morse.
Yes.
So Michelle and a number of other colleagues, you know, Michelle I think she was trained there, but anyway, she was working at Brigham's and Women's Children in Boston. That's like the Harvard of the hospitals. It's big time stuff. Michelle is a sister. She's presently the chief medical officer for the New York City Department of Public Health. But in any case, they did a study. She and one of her and a bunch of her colleagues, they did a study that looked at patient care, how patient care was being done at Brigham's and Women's. And they found that the people who got, I think it was about cardiology, if my memory is right.
Heart failure. It was
heart
failure.
Okay. And so when they looked at like 10 years worth of data, and they found that the Black people who had heart failure didn't get to the ICUs and the specialty care as fast as white people did with the same, conditions, the same data, the same blood pressure. And they published this. They said, this is clearly structural racism. We got to do something about this. And it was published, well done study. Earlier this year or last year, a bunch of neo-Nazis have come out there and said
4 weeks ago,
Brigham and Young is trying to kill white people. And they targeted Sister Morris, Dr. Morris, and they targeted that was one of the white men that was one of her lead colleagues. Right. And they're saying, you have to stop this nonsense. You're killing white people. Why? I guess because we were going to say, well, we need to put the sickest people in the specialty care. That's how we usually think about this particular area. So the people that are the sickest that are going to benefit most from the specialized care, that's who needs to go there based on medical need, not based on the color of your skin. Right. So this stuff is going on today.
They came back. Mm-hmm. The Nazis came back just last Sunday.
Okay.
They were back, not around Michelle and Brahms thing, but around another thing. But the first, when they came out about Michelle Morris and Bram Wispelry, that was 4 weeks ago. And it was, Brigham and Women is killing white people. And what they were doing is exactly providing resources according to need, but they weren't even using race as a thing. They were it was a flag. It was a flag in the medical care system who was saying, do you really want to send somebody with these symptoms just to the regular medical floor? Because we have evidence. It was just a flag. We have evidence that this happens disproportionately for Black patients. So it was just a tickle.
So it wasn't that was their fix to put it in after they found it.
That was the fix. Right. And people are saying this, but they were there last Sunday on a different thing. But instead of 20, 25, there were 75 now. Mm-hmm. And this time they were saying it was because a heart transplant person who wanted a heart transplant refused to get a COVID vaccine. You're going to get somebody else's heart that somebody else might need, and you're not going to protect it with a COVID vaccine anyway. But they are feeling their oath. So they have tripled in numbers. The next time that they get on something, which I'm thinking might be in another week or two, there might be more. We need to recognize this pushback and figure out how are we going to equip ourselves. And I don't have the answer for that, Linda Ray. I mean, I want you to come back to how we're going to teach history thing too, but I'm asking you these questions because as we try to do stuff that is about providing resources according to need, which is one of 3 principles for achieving health equity. The second would be recognizing and rectifying historical injustices. The third, which I actually say the first, is valuing all individuals and populations equally. If we're going to do that, but the most important, providing resources according to need. Many white people out there might be thinking, when you say equity, you are saying anti-white. They think that if you are going to address the status quo, if you're going to disturb their comfort at any point, they are thinking that there are 2 states of being, disadvantaged and normal. Why are you going to come after their normal? Right? When in fact, there are 2 states of being, 2 states of being disadvantaged and advantaged. They don't recognize that their so-called normal is built up on a whole mountain of advantage, and they don't want to know it. They don't want their children to know it. You know what I'm saying? So it's a cycle there. And so we're in trouble here until we recognize that the resistance on that side is highly motivated persistent and dangerous.
So yes,
Dr.
Mark.
Murray, let me ask both of you all this question. Feel free to jump in. I'm going to touch on that. How do we teach this? And I'll just give you an example. Some people might say, "Oh, Dr. Jones, Dr. Murray, they're MDs. You know, they're financially successful. They can afford mentally and financially to speak the truth." So it's a two-part question. First, how can we start teaching it, and how can we start getting those? And it's not just about black and white. How can we start getting those brothers and sisters that are in the restaurant to start speaking up and opening up the door to let us in? And I just say this often in research and dealing with academic folks, and I'm gonna pick on academic folks right now. The black folks are usually scared to add that soul or add that that cultural experience to their studies. A fear, and realistically, they want to pay their bills. If you start speaking out too much against the man, you're either gonna get killed, financially killed, ostracized, something. So that's pretty a long question. So how do we teach? What venues or how do we teach them? What do we do to counteract? For the sake of this conversation, those brothers and sisters that are scared to be themselves.
Well, let me deal with the psychiatric question last. But let me start with what I think is so let me give you an example. I don't know about Camara. It's a failing on my part. But it's current in the literature today. There are many indices that we use in clinical medicine: kidney function tests, heart failure indices, pulmonary function tests that are racialized. The algorithms are racialized. So imagine. So I was in medical school in the 70s. I'm sitting there. I'm a child of the 60s. I'm a revolutionary. I'm sitting in class, and then you go on the ward. And so the other thing that happens is you go on the clinical wards, on the hospital wards, and you're almost always by yourself, and it's very small, 2 or 3 other students. So when they lectured in class and said, black people have more muscles, and so they have higher creatinine, and so we need to change the creatinine. I'm not stupid. I'm sitting up there saying, like, that doesn't make sense. I'm saying, why would black people? First of all, who said black people have more muscle, and why would they do that? And what that does? So this is with kidney function. So they artificially lower our kidney function so that we appear healthier than we really are, and therefore we don't have the same access as whites who aren't artificially lowered to these specialized services. And it's not an accident then that we have such a high rate of death from end-stage renal disease.
Right.
But so this is, I'm not using this as an excuse. I'm just explaining how this happens. So that happens in a whole number of pulmonary function tests, like in what universe? And I even knew about scientific racism there. I'm saying, like, this sounds like some ancient bullshit. There's so many things we do in medicine that are passed down almost ritualistically that haven't been rigorously proven. Something like basic, like aspirin. I'm not sure aspirin would get approved by the FDA today. I don't, So we carry in medicine, in clinical medicine, stuff from the past. Now, and so this is my analysis of what happened. But I'm a general internist. My area of specialty is not these areas, and I practiced medicine for years. And the lab prints out the lab results, and they make the racial adjustment. And I didn't challenge it because the amount of time and energy, even though in my mind I said something's wrong. Some people don't even think something's wrong; they just accept it. But the time and energy to really prove that it's wrong is challenging. So what's happened now? So now, in my retirement, we do have more black specialists. We have more black specialists proportionally to now than we had when I was in medical school. And so our nephrologists are saying, like, this is some racist shit. And they're doing the work. And the black cardiologists. So now you have enough professionals who can collectively challenge. You can't challenge it by yourself. They collectively come together and they say, this doesn't sound right. Let's go back and read the original papers. And they, and there's nothing there. And then they do the kind of studies that like Camara is talking about. It is a major effort. But now we're getting some progress. We're making slow advances. Heart disease, heart failure, thoracic surgery. There's so many other things that go on in medicine that are inappropriately racialized. In 2016, there was an interesting survey of lay people, medical students, and residents. And they asked things that were racist from 150, 200 years ago, like blacks have thicker skin. Okay. Mm-hmm. And I can't remember the numbers. I don't want to misquote them, but an extraordinarily high number, because there should have been zero, of medical students and residents said, yeah, blacks have a higher skin. I'm saying, like, where? I missed those lectures. I was never in a lecture to say, like, where did they get this from? This is clearly some stuff that is in the culture that they believe.
That's right, which explains why we don't need as much pain medicine, right? And that why if you come in with a sickle cell crisis, you are drug seeking as opposed to illegitimate pain. All of that stuff is in there. But Linda Ray, I just want to say, you are saying now, people are better and stuff, but I challenged stuff before. My whole dissertation after I left from medicine to epidemiology was challenging the notion, which at that time was that Black folks had more hypertension because when we were brought across in those slave ships, that the ones who survived had some genetic propensity to hold on to salt. And now that we were in a salt-rich society,
but you didn't believe that, though.
I did not believe that. I did not believe that. And so I started studying blood pressures, and I wanted to look at full distributions of blood pressures. I wanted to say, I know even before we mapped the human genome, right now we have mapped the whole human genome. We know there's no basis in the human genome for racial subspecies. But before we had done that, I knew that, you knew that, right? Like, we knew that. But it made me start asking different questions of the data. So when I was trying to explain, why do we have these Black-white differences in hypertension when I know that our kidneys, that we're all human, right? That we're all human, and especially that people who are called Black, getting back to your one drop rule, represent a genetic admixture. Look at me, from all different kinds, American, Indian, European, African, from all different parts of the Africa. We represent a genetic admixture. So we're not even talking, when we talk about Black, but use that socially assigned race, we are actually the most heterogeneous. Some people think that the reason that we need to have Black people, and it's good to sign up to be organ donors and all of that, is because Black people are so particular that Black people can only get a kidney from another Black person. It is actually that we are so diverse, right? Because I know I'm wondering, but if a nuclear bomb wiped off everybody but a few people in the African continent, from those people we could generate almost all of the genetic variability on the planet, right? We are so diverse in our genes that is why we need people to be bone marrow donors and all of that. So it's not that we're so particular, it's that we're so broad. But anyway, I digress. So I knew that this was wrong, and I would love to talk, not right now, but in a minute, about what I learned from looking at blood pressure, which basically was my accelerated aging hypothesis.
No, go ahead and do it now. Go ahead.
Well, there's so many different things that as I was writing, you were so stimulating to me. I guess I'll go and I wanted to get back to Brother Murray's question first about people afraid to use their power and stuff like that. And then I want to go to that because there are a lot of people. I saw it in government bureaucracy. So I spent 14 and a half years at the Centers for Disease Control and Prevention, the CDC. And I witnessed Black people in positions of power, afraid to use their power, afraid to even use their power to put something on an agenda like racism and anti-racism, or afraid to use their power to speak up in meetings, or afraid to use their power to bring in a summer student, or whatever it was. And they were afraid to use their power because they were trying to get up to that next rung. And yeah, when they got to that next rung, then they were going to be all out there and using their power. But if you practice holding in your power, then when you finally think you have enough of it, you still won't use it. So what we need to do is practice using our power wherever we are, because we all have power, even as individuals, wherever we are. But I agree with you, Linda Ray, so strongly about the collective action is real power, because collective action is going to inform us, like you're informing me. I'm informing you. We're informing others right now. Collective action inspires us. collective action propels us, and especially collective action protects us. So that was another thing that I wanted to say, which is if you are inside an institution trying to do something and the institution is not quite ready to hear you, then you keep trying. I've left institutions after trying and getting some progress, and then like, oh, I can't give myself breast cancer, right? Or something like that. But if you are in there, it behooves you to have community folks on the outside who know what you're trying to do. And then when you say they are coming down hard on me, the community can speak up. They can, when I was at CDC, if they write a letter to the CDC director, somebody has to respond to that letter, right? So that
I want to tell a family story to answer Marcus' question too.
Okay. So let me just finish that little bit. And the people on the outside and we're all inside and outside different institutions. The people on the outside need to know that those institutions are not just like a big old monolith that you can't penetrate. They need to know that there are people inside who are trying to do good things for community. And they need to know that there are people inside who might give them, give them a heads up if there's some input needed or there's investments available in the community or whatever. But the biggest job for us right now is not just to understand our inside or outside, but to make the institutional walls more porous, to make it easier for people to have this inside outside kind of strategy going forward. Okay, so Linda Ray.
Let me tell you my two quick stories. One's a family story. So my great grandmother was born during Reconstruction, and when I was a little girl living in the projects in Cleveland, she spent a summer living with our family. She would travel around among the family. And her people, her parents and uncles, actually owned land. After the war, they had some land, and in the summertime, she would call us in around lunchtime, and she said, "Come in out the sun. You're gonna get black," which always pissed me off because I was already black. But then she would tell us stories about when she was a little girl and about how white people were, and I got disturbed over this. This is pretty frightening to a little girl. And I asked her, well, what are you supposed to do? Because, she would say, if you go to school, that, it doesn't matter. They're always going to mess with you. You got to be twice as good to earn half as much, all of that stuff. And so I said, well, what can we do? What can we do that's right? And she looked at me and she said, that's easy. She said, you're a black girl. White people are always going to knock you down. And the only question you have to answer in life is how many times you stand up. And that's what I think about our brothers and sisters that get promoted. Look at Brother Flores. I don't know Brother Flores, the quarterback. What team is he with, Marcus?
He was a coach, Miami Dolphins.
With the Dolphins. I'm not saying nothing about him one way or the other. I don't know anything about him, except he seemed to be a good coach. But when he made this decision to sue the NFL for racism, there's a good chance they'll treat him like Kaepernick. He may not ever coach again.
He's never coming back. It's sad. He might be able to go to college.
So the reality is, I don't care. You may get to be a dean. You may get to be the CEO. Let me tell you something. They're going to fire you faster than they'll fire a white CEO. That's going to happen because you're black and racism is structural in nature. And I agree with Camara, you have to have outside support and stuff. But if you truly understand the nature of racism in this country, then you can never escape being black. And you might as well use your power. You might as well stand up every time they knock you down.
Yes.
I want to give you one other example, which I would not know about. Didn't surprise me. So, now that I'm retired, I serve on a number of community boards. And for the All of Us program, let me just call it out, which is a program that the feds are using. And it's controversial. It's a controversial program. And some of that controversy has been written about in the literature. Well, I agreed to be on the community advisory board for this. Most of the other members of the advisory board are, they're not medically trained. So we would have our meetings and stuff. And I would say, well, I think it's important that the community, that this board know this is controversial. Here's some articles that are arguing about this approach and stuff. And the staff was great. These are great young professionals, well-trained, generally public health people. They went, I'm going to call his name. They went to Dr. Wynn, the head of our cancer center at that point in time, and said, Dr. Wynn, we think maybe Dr. Murray shouldn't be on this community advisory board.
Oh no.
And he said,
oh no.
Why do you think that? And they said, sincerely, these were predominantly people of color, by the way. They said, well, Dr. Murray knows too much to be on the board. And so Wynn said, but Wynn, he taught them a lesson. He said, do you understand how racist that sounds? Are you saying a community person can't know this literature? A community person can't have technical skills? A community person, what you say, she doesn't have a community because she has an MD? So even when it's very difficult to fight for yourself. I've always found it difficult, but you can, in your position of power, you can fight for people underneath you to have some power. You can fight for real integrity from the community, which will eventually help you. Nobody believes me, but I would often say, it's not me talking crazy stuff. It's that neighborhood and that neighborhood and that neighborhood, which was true, but so I think that being in collectives, whether they're unofficial underground collectives, whether they're things like the American Public Health Association, et cetera, and we certainly have our battles there too. I think this is the critical thing, because if we don't do this, then we're going to continue to slip backwards. It's not an accident there are fewer Black medical students, Black male medical students in medical school today, proportionately, than when I was in medical school. So what have we accomplished by all these people having some power?
Right.
Now I'm sorry, I gotta ask this question, Dr. Jones. I wanna spark a nerve with you and Doc Murray. Mm-hmm. So when Doc Murray's talking, so first let me say this, just throw this out there, it's not a question. If they have those same principles that are messed up about Blacks in terms of medical and the physical body, just imagine what they have about Blacks and health behaviors and how they want us to conduct studies. I just want to throw that out there. Mm-hmm. Dr. Jones talked about a waste of human resources, which to me trickles down to, tons of things. But it goes directly into what you just said, Dr. Murray, about the lack of Black men in medical school. So I want to throw this out there because you all are saying good things. It's one of the problems that our so-called powerful Blacks or our so-called powerful Black leaders didn't create enough institutions where these things can be taught and the truth can be taught, that we probably spent too much time and our energy serving other institutions?
I think that there's a real power in institution building. And so, yes, I mean, when they were trying to kill me at CDC by telling me I needed to take unfairly advantages individuals and communities out of my definition of racism, and then they started canceling my talks. Linda Ray remembers when I had APHA, I had like 7 talks and a poster, and they canceled my travel. I ended up going there, but I couldn't say anything. And I said, Dr. Murray, past president of the American Public Health Association, will you get up there and speak in my stead? And so they were really trying to kill me. And it was because Dr. Satcher, a former Surgeon General, 16th Surgeon General, former CDC director at that time at Morehouse School of Medicine, he helped me escape from CDC to the Morehouse School of Medicine, a historically Black college and university, not that historical because it's like 45 years old or so, but it's a Black serving medical school, and it's included as one of the 4 HBCU medical schools, which were Howard and Meharry, and then Morehouse School of Medicine and the Charles R. Drew University of Medicine and Science. So those are the 4 institutions that we have now. Used to be a whole lot of them until the Flexner Report in 1910, where Flexner was saying, well, the way that medical education really needs to be done is such and such and so, and it resulted in closure. I think there were 17 and it boiled down to 2 or something like that. You might have to give me the numbers.
By the time Flexner Report, there were about 17 originally, but the time Flexner, in 1908, there were 7 left.
7 left.
Flexner
Okay.
Report came out in 1910.
So there were a bunch, then there were fewer, and then now we ended up with 2. But that, I was saying that to say we need these institutions. Even when I was that first week that I was over at Morehouse School of Medicine, so I've been teaching at the Harvard School of Public Health, at CDC, leading this, racism and health work group and trying to do this work. And here they were trying to kill me. Honestly, I felt that first week at Morehouse School of Medicine as if their deliberate attempts to shorten my life had been interrupted by my being able to escape. And I just felt waves and waves of, of the tension just rising that first week. Our institutions are important not only to tell the truth, but also to recognize all of our diamonds out there, the diamonds in the rough and the diamonds that have already been polished and shaped and faceted, and to train us up. So yes, I do believe in institution building. I never went to anything but a predominantly white institution. So, I'm still affiliated with Morehouse School of Medicine. I taught in their community health course, 5 years, as a core faculty member and all that before then I went up other places. Now I'm sort of like a visiting faculty all, at Harvard and Yale and UCSF and all like that. But what I want to say is there is that place, but it doesn't mean that all of us need to go there, but we need to have those places for people to go. Most of our Black professionals, I don't know the statistics, I would say bankers or attorneys, have come out of HBCUs, So yes, we need the institution building.
I mean, even more so than just institutions like Morehouse School of Medicine. There's even organizations around like the Council on Black Health, the Black Caucus of Health Workers. There's Project Brotherhood. There's entities that want to support you all's vision, support you all's dreams. Like, I know my mother's story, so I'm not going to go in and I get pissed off when how she got treated. But hearing how the CDC, this entity that's supposed to be so great, treated, it pisses me off. Like, what are the brothers and sisters first? Well, I'm glad Dr. Satcher helped you out and grabbed you up. But Dr. Jones should have never even been in that position. We're supposed to have our own version of the CDC that's funded by our Black elites, with our Black our people like you, Black excellence, steering it. Because if we keep going to them to put out our work and to justify stuff, it's not going to happen.
But they still have the money.
Right.
They still have the power.
And Marcus, you know what I think about this. I think we have to be really crystal clear. This is my attitude toward the University of Illinois, which all my degrees are from, and I can't stand this. My attitude is that's the state school. My taxes support that school. We built this country. So even though the HBCU, I'll tell you in medicine, those HBCUs of 4 schools, they have, I don't want to give you the wrong number, they disproportionately produce Black doctors. Xavier, in New Orleans, as an undergraduate school, produces more Black people that go on to medical school than any other college in the country, okay, and has for years. But let me be clear. We disagree. This is normal. This doesn't mean we're inferior or anything. We have been raised in the belly of the beast. We don't even think like the rest of the world as Americans. And so we collectively disagree on what things are supposed to do. I'm not interested in replicating an elite. I'm interested in Black excellence. And so when you make a decision, well, I want to produce a Walmart that's Black. No, I don't want to do that. Or I want to produce an Amazon. No, I'm not into that. So one of the issues we have to understand is, what are the roles of these Black institutions? I know we're going to have political differences, but one of the things and let me be honest with you, I support HBCUs, but their role, for example, in the civil rights, for after Reconstruction and up through the civil rights movement, the modern civil rights movement, was not progressive at all. They tried to keep those students down, expelled students and shit. They were expelling students in the 1920s and 1930s that were raising political ruckus. And to some extent still do that sometimes today. So we need to understand as a people, we need these institutions of all different kinds, but to think that we can by ourselves replicate this multi-billion-dollar institutions, that is not going to happen. We need to demand justice for all of our institutions without losing the characters that we need for HBCUs, Native American schools. This is true everywhere. Hispanic schools do better with training. Native American schools, all of them do better for lots of obvious reasons. So, but we cannot just say, this is what I've heard this all my life. Well, if we were like this, the white people, we would be, no, it doesn't work like that. The white people don't support everybody, first of all. They may privilege white, but they support their brothers and sisters. And So we need to fight for justice.
Doc, I think you went on some personal things, like
No,
your
I
own
didn't. I'm
personal
just saying.
beliefs. I'm not
To,
talking about multi-billion dollars entities. I'm talking about places and platforms where Dr. Murray's and Dr. Jones's can preach, teach, and feel comfortable that they won't be trying to get killed and harassed.
we need to build those. I agree.
People want to listen to you all. So I'm not saying we create a HBCU. I was just asking questions about platforms and entities. Often, and I'm going to use me for an example. I used to sit on a lot of little community advisory boards for these academic institutions. And then I realized it wasn't making sense. Here it is. I'm trying to fight from the outside. It got to a point where I was just helping them get bigger and nothing was coming back to the community. Right. So, and I'm not necessarily talking on a big macro level. I'm talking about micro. And I'm not going to use you all for this. Well, yes, I will. If Dr. Satcher, Dr. Jones, and Dr. Murray created an entity, that entity right there, based on you all's network and knowledge, is a sure competitor for some of these smaller research funding grants than some of these academic institutions who really don't give a damn and just want the grant money for the indirect. So we don't have to go into that. That's a whole nother talk. But it's more about how do we teach, how do we let Dr. Jones and Dr. Murray have platforms where their truth is being heard, and it's in a safe space for you guys as well.
Well, I really appreciate you. I appreciate you, Brother Marcus, because why haven't I done that? Because I recognize what you're saying is true, and it's because I don't know. I don't have the family that did that knew how to set up an independent institute and all. And I know there are people in our community who could help me. So maybe what you're saying tonight is going to make me call up your, Linda Ray, and maybe we will set something up. I know I do have friends, especially younger friends, who are doing that, who are setting up their own businesses so that they can speak their truth from their own place. That's important. So
for the sake of this conversation, I'm winking. We're not going to talk about it because we don't want people to shut us down, but I understand what you're saying.
May I say two more things?
Yes,
you
please.
Were talking about collective action, which we have all been talking about. There's this image I use of geese, and I just want to share that with, why is it important for us to have some other folks around us as opposed to be striking out on our own? We all do have individual power, but that collective action can protect us, propel us, inform us, inspire us. So I used to wonder, when you see geese flying, you see them flying in a V formation, right? And the reason they do that is because the goose at the front is breaking the wind for the ones who are behind, who are breaking the winds for the ones behind. And I started wondering and worrying, really, what happened when that goose at the front got tired? Do they just drop off someplace or fly off someplace random? And no, geese don't do that. When that goose gets tired, they move back and another goose takes the lead. So I actually think that our job in whatever setting we're in is to either identify or create our flock, decide in what direction are we going, and then take turns in leadership and spell one another so that it's not so hard, so it's not impossible, so that we can keep moving in the direction, we can keep flying, and different people keep breaking the wind. And we need to do that intergenerationally too. We need to be about mentoring people. That's why this, the young health professionals, as the host for all of this, is so important. I start thinking about batons, like in a relay race, and you pass the baton back. I'm thinking myself about barrels of batons, and I'm like, shoo, shoo, shoo. I'm passing back barrels of batons, and I'm hoping that everybody who grabs a baton from me will look at it and at least use it as an inspiration. Maybe they don't have to make the same baton, but they make their own barrels of batons, and that we're amplifying like that. So I wanted to say that. The other thing I wanted to say is that when we wonder about Black folks who get into positions of power and yet don't either fully recognize the power they have or are afraid to use it, many times I think that those of us who are successful have bought into the myth of meritocracy, that if you work hard, you will make it. We have been influenced by our narrow focus on the individual. And we are ahistorical. And I'm going to throw one more in here. I have 7 things that are happening in this country that I have started highlighting as the roots of racism denial. But in this particular example, belief in that myth of meritocracy being narrowly focused on the individual, which makes them feel like they got where they were because they were smart and worked hard, without, then when you add the ahistorical on that, without recognizing that there have been, centuries of smart, hardworking Black folks who didn't get where they were, that they are standing on the shoulders of others. And then to add to that, the 4th root of racism denial, which is white supremacist ideology, maybe they themselves believe some of that, right? And do not believe that they are fully powerful or they can do what they need to do. So that's a problem. When I was in New Zealand for 8 months, if I were, you had me introduce myself at the beginning of this. If I were in any Maori setting and I was meeting people, cocktail party, whatever.
Tell people who the Maori are.
Okay, so the Maori people are the indigenous New Zealanders and they've been there about probably 1,200 years, because before that was probably just birds. But anyway, they're a Polynesian group who arrived in New Zealand on 7 canoes, right? They now are about 10%, 12% of the population, just like Black folks were. I was there in 1999. The parallels between the Black health status with regard to white in the US and the Maori health status with regard to the white British descendant New Zealanders. The Pakeha is the Maori term for white folks. It's not derogatory, it's just the Maori term. But the Maori Pakeha health disparities were similar in kind and degree as the Black-white health disparities. So I went there with the question, Maori Pakeha health disparities, can treaty settlements reverse the impacts of racism? So I did all this work. But anyway, and it's interesting, and if you want to see what I said, including about what I learned about reparations to US folks in our context from the treaty settlement process that was happening in New Zealand, you can just probably Google Camara Jones, Ian Axford, IAN, Axford Fellow Report. But anyway, what I was going to say is, if I were Maori, I would introduce myself by saying, my canoe was such and such. My mountain is such and such. My river is such and such. My great-great-great-great-grandparents were so-and-so, so-and-so. My parents were, and I am. It could take a long time, right? But I was so struck, because I can't even right now today name you all 4 of my grandparents. I mean, I have at some time known, but if you ask me right now, I think I would fail, right? The difference between Black folks who were brought here against our will, enslaved, separated language groups, drums taken away. We have no idea really of our history unless we explicitly go and try to learn it, which is why I'm so interested, Linda Ray, in what you do, right, in your class. We don't know what boat, and it wouldn't have even been our boat, but we don't know what boat brought us. We have no idea about what mountain, what river, none of it, which explains a few things. It explains why we are so creative, even with our names, right? Because I feel like we're like in an ocean by ourselves, just trying to sink or swim. We're creative. We do not understand that we actually really do stand on the shoulders of others, and that we need to stand tall so that others can stand on our shoulders. Instead, we're kind of just in it, just trying to make it, right? That lack of history of grounding, even into how we can introduce ourselves, that was like, whoa, you have to go a place to like really understand what's going on in your own country. But anyway, so I just want to share that, and this whole notion of Black folks thinking that they got someplace because they were smart and hardworking. Yes, not taking anything from you being smart, not taking anything from you being hardworking, but you also have to recognize the role of other people. You need to work with other people even now, or as Linda Ray said, they're going to just snatch your job right out of you, right? They're going to just send you packing. So that's enough talk for me right now.
So Doc Murray, back to something you mentioned earlier. You were talking about Black males and just Blacks in general in medical school. How does that have a direct impact on health outcomes for Black folks?
Well, again, first, let me just say this. I don't care who you are in medical school, you need to understand the history of American medicine and how deeply seated racism is in American medicine. American medical community, American physicians were one of the key contributors to this ideology of white supremacy. Mm-hmm. So that's important to understand. I think that the structural problems that we have in terms of getting blacks into medical school have gotten worse. So when you close public schools all across the country, for example, to use Chicago, when you were in the 4th, 5th, 6th grade, over 20% of Chicago public school teachers were black. Today, it's under 10%, more like 7 or 8%. You know, that happened in a deliberate, methodical way. The number of Latinx teachers have never been that great, nowhere near where they are in the population. When you structure things so that people can't go to college, I think we forget this is what happens when you're ahistorical. So, for example, if you were in World War II as a soldier and you were a veteran and you come back for veteran benefits, when you came back, if you got into Harvard, which was expensive, they paid your full tuition. They paid your full books. They gave you a living stipend. Today, you can go get injured somewhere in Afghanistan or something. You come back, you have much less money. You have to use it in a certain time, and people often it expires. So the actual conditions that we are under have gotten worse. And so that is one of the major problems with getting black men in medical school. I think people get psyched out and afraid to apply to medical school. Today, now Camara and I had to take what's called an MCAT exam. It's an entry exam that you could take. And I remember I was working. You were a baby, Marcus, but I was working. I was working, earning money to feed you, and I still had some money to go and take a review course for the MCATs because I figured I needed every advantage I can get. Today, when I work with students today, to take even a simple online review course, you're talking about $2,000. To take an in-person review course for these exams, you're talking about $7,000. This is out of the range of people. That makes it very difficult to even get in. And even once you're in, a lot of times to get to to become a surgeon, to enter one of the specialties, some of these programs won't even interview you if your scores on our exams, our national exams, are too low, which we know have no relationship. We know the MCAT does not predict how you're going to do in medical school or as a doctor. And we know the scores on national boards doesn't predict it either. So one of the things that's happened, which I am very grateful for, is as we got more and more black people in positions of power in medical schools. You know, when I was in medical school, we had 2 black faculty at the University of Illinois, one of the largest medical schools in the country, 2 black faculty. But as our numbers have increased, not enough, but as they increase relative to the past, we have now forced the institution to make that first exam boards pass-fail. So no longer are they going to be able to say, we ain't interviewing you because your exam is 10 points under what we want. That is a major structural barrier removed. So I think that there are things we can fix. There's no reason why we cannot get black men in school. And when we get them in there, we have to support them. All students of color, black women, black men, but other students of color, medical school is stressful. And it's especially stressful if you're a person of color. And so we have to support that and fight for changes all along.
Did you know that that NYU is, I guess now for maybe the past 5 years, is totally free for all of the students they accept? So
Yes.
People need to know that there are 3 schools. The Kaiser Medical School out in California, its first 5 years of classes are going to be completely free for those. And I think they may be in their second year of classes. And there's one more that's somewhere, maybe in Chicagoland, I'm not sure. So just to say that if the financial, I know you were talking about the financial barriers of applying and studying for the MCAT, which are real, but sometimes people also think, oh, it's going to cost too much. But there are some free, which makes them very competitive. But there's also the National Health Service Corps as an option for having the government pay for your medical school and then having a year-for-year payback commitment to work in a medically underserved community, which could be urban or rural. My husband did that for his last 2 years of medical school. And
but even that they've cut back on. They've cut back on how many scholarships are available for that, and they've cut back on how many loan repayment. So we've been creeping backwards. But the point you're making is right. And there's certain standards. This was I fuss with U of I all the time. I worked 40 hours a week my first 2 years of medical school with a 2-year-old as a single parent. And they didn't care. Their attitude was, in fact, when I got accepted to the University of Illinois Medical School, I went in to arrange for financial aid because I'm a single parent. So Marcus is about to be 2 or something. And so, and the guy told me the dean, he was a dean of the first year. He said, well, if you really want to be a doctor, which we don't think you're going to be, think about that now. I have not sat in one classroom.
Oh no.
He said, well, we know that your chances of finishing in 4 years are nil, and your chances of finishing at all are pretty slim. And if you really want to be a doctor, you need to put your son up for adoption.
Oh,
that is what he told me.
Oh no! Did you report him to anybody, or you just took it because that's what he was going to tell?
So again, people don't. I don't want to be ahistorical. So, like I told you all, I'm a child of the '60s. I'm a big bad revolutionary. So what I said to myself was, "What do you expect a white man to say?" I mean, it's like, you're a racist motherfucker. I already knew that before I walked in here. So what did I say? I said, "No, I ain't putting up my son for adoption." So. In fact, since we're about to finish, since we have so many students here, so let me tell you, I was first came to Chicago to go to the University of Chicago. I was a math major. That's what my degree is, an undergraduate degree. And when I decided to try to go to medical school, it was late. I was like a third-year student. So then I couldn't afford, I said, I got to go take all these pre-med courses I haven't taken. So I transferred to the University of Illinois. I didn't need no financial. I went to work for the CTA and I went on to school. So right when I was getting my last year, I was going to graduate in June. They called me in the fall. They called me in the office. They said, Linda, why are you still here? You're taking up valuable space. Because by then I had all of the courses I needed to be a math major, right? I came in there with 3 years of math from the University of Chicago. So I had finished all my degree requirements. And I told them like an idiot, I said, well, I'm planning on going to medical school. They said, you can't go to medical school. You can't get into medical school. We are kicking you out at the end of this semester, which would have been December. And I still had some courses. So, but again, I'm a revolutionary from the 60s. I walked down the hall and changed my major to art history. Because I didn't have one course in art history. So I officially changed my major to art history and said, kick me out now. I don't have no courses. And I graduated that June. I just, I changed it back and then graduated in math. So again, these little personal things, but these are structural things that make a difference.
So Dr. Jones, can I ask you something? It's related to this. It's something you wanted to touch on earlier. So what my mom went through, and I don't know how she deals with this stress, and I'm glad she didn't tell me their names. I definitely would have hunted them white folks down, well, if they was black at 15, 16 years old and I was a knucklehead. But you talked about blood pressure and age acceleration. As Black folks, and I'm going to speak for me as a Black man, what I have to deal with going out on the street, dealing, and how people perceive me, even if I don't care how they do, that stress and that blood pressure, how does that affect me and my overall health?
So we, not from my studies, I'll tell you about other people's studies and my studies, but we know that Black folks' blood pressures in this country are elevated compared to white folks, but not only are they elevated during the day, they don't even drop down at night, like white folks' blood pressure drop down. So we are basically like gunning our engines constantly, which then, results in, thickening of the heart muscle. And then maybe you have a heart attack, and then that results in the heart failure that we're talking about, that now your heart can't pump, well. But then the high blood pressure also affects your kidneys that we've been talking about. It can affect your eyes. It can affect all kinds of things. It can affect your blood flow in your legs and all kinds of things. So we need to, and it's silent until it affects you in that way. That high blood pressure, you can't necessarily know when your pressure is high or not. So that's why we need to check our blood pressure at least once a year in a regular physical exam. Some people buy the high blood pressure cuffs in the drugstore. No, I can't say one versus the other, but I went in to have a dentist, and they had this new kind of blood pressure cuff on the wrist. I hadn't seen that. So anyway, but my studies on blood pressure, as I said, it was because I rejected the explanations for black-white differences in blood pressure that were out there at the time, which was about salt retention and, renin angiotensin system being different. And I was like, oh no. And so what I did, I said, first of all, I'm not just going to compare black folks and white folks for their average blood pressure. I am going to look at the full distribution of blood pressures in black folks and white folks. So let's say we had 100 black folks and we checked everybody's top blood pressure, their systolic blood pressure. And that top blood pressure went, there's one person with 90, and then maybe there were 3 with 94, and then there was whatever. And I would stack up all of the bars, how many there were, and make like a bell-shaped curve, usually, of blood pressures. That's the distribution. When you look at that, you notice that curve has many characteristics. It has a main central point, which is what the average blood pressure would be, but it has spread around that central point, and it has shape, because sometimes the curve might be with 2 humps, or maybe it would be really skinny, or maybe it would be shifting off to one side. When we look at distributions, we can learn so much more about a thing than just looking at the average. Or what other people do is they say, well, we're going to have a cut point, 140 as the systolic blood pressure. If you're that or above, you have high blood pressure, and below, you're good. Well, we know things don't work in cut points, but that's another way that people look at it. You don't get a lot of information from looking at averages or using a cut point, So I looked at this most powerful way that you can look at comparing distributions. The long and the short of it was, when I was looking at women from 3 different studies over 40 years, national examination studies. So national data, lots of data, comparing black women and white women from as young as really girls, 5 to 14 was one age group, then 15 to 24, 25 to 34, and so forth. At the youngest age groups, the blood pressure distribution for black girls and blood pressure distribution for white girls were nearly identical. How do I know that? Because I developed a whole system of statistical methods for the pairwise comparison of continuous distribution. So now that's another whole, week on my methods. But I am, and a methodologist, right? So these new methods told me that not only did the distributions look the same, that they were not different in location, spread, or shape. They were identical. Then you get up to the 15 to 24. By the time you got up to comparing the 25 to 34-year-old black women to the 25 to 34-year-old white women, the black women's blood pressures were shifted to higher values, and it kept on like that. And even at the oldest age groups, the black distributions looked like they were bimodal, that they had a hump. I was like, well, I need to figure out what's going on here. So then I created these methods for adjusting distributions. We know how to do adjustments and regressions, but I created a new set of methods for adjusting distributions, and that still didn't get rid of the difference. And then one day, I made a mistake. I was trying to plot black, white, black, white, black, white, same age. But what I ended up plotting was black, 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 black with age, and white, 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 white with age. So anyway, it was late. I went home, go to sleep, wake up another day and reprogram. In the middle of the night, I had a real eureka moment, which was, I realized that for both black folks and white folks, the blood pressure distributions were moving to higher values with age, but it was happening faster for the black women compared to the white women. I ran in the next day and did what I called my age shifted comparison. So now I'm comparing black girls who are 5 to 14 with white girls who are 15 to 24. Black girls who are 15 to 24 with white girls, women who are 25 to 34, and so forth. In the youngest comparisons, of course, where they were identical, then the white folks were slightly ahead. But by the time I got to the 25 to 34-year-old black women in their prime, with the 10-year older white women, those distributions were identical. And that identicality kept going on. And what it showed was that the way that blood pressure was increasing with age for black women was accelerated from no difference in childhood by about 10 years. When I saw that across all of these, now 3 studies, all of these things with my methods, it led me to articulate what I called my 2-part accelerated aging hypothesis. Part 1, that black-white differences in health outcomes across the board. I had irrefutable evidence with regard to blood pressure, but you think about how they talk about screening for glaucoma in Black men at age 40 and white men at age 50, or prostate cancer, we get that earlier. You think about Black women and getting breast cancer earlier and all that. My hypothesis, first part, is that the black-white differences we see in health outcomes across the board are due to the accelerated aging of Black folks compared to white folks in this country. The second part of the hypothesis is that accelerated aging of Black folks compared to white folks in the US is due to racism. I came out of my doctoral dissertation with that. I started developing measures of racism, trying to convince people that racism exists and all that. But I am returning, because although people are now, I never published it in a paper. I published it in my dissertation, right? But I presented for about 8 years at the cardiology this and the American Public Health Association 3 or 4 times on my accelerated aging hypothesis, went up to teach at Harvard, presented to people, poo-poo, not my colleagues now, if you ask them, they're all talking about accelerated aging, right? But I never published it. Anyway, but I know it's true. People still haven't caught up. I only published one of my methods papers. If people really wanted to catch up with it, they could do that. But I am going to turn back and get back into that game because people haven't caught up to what I already know because of those methods. But that's a real thing. That's a real thing. So it's not genetic. There are no genetic differences between Black folks and white folks. It is because of racism, not so-called race, which we interpret to be genetic, when actually it's the social interpretation of how we look in this race-conscious society. It is racism that is accelerating our aging. Now, we look good on the outside, but inside we're a mess.
So we got to find some ways. We got to find some mindfulness stuff, and just attack racism on a social justice level. Dr. Murray, we're running out of time. We definitely have to do this again. So, Dr. Jones, what we do is at the end we go around and we let people just talk about, for 30 seconds, anything they want to. To give you an example, I'll let Dr. Murray close us out. It could be funny, it could be serious, or whatever. Dr. Murray, close us out.
Well, first of all, I want to thank you so much, Camara, for coming on, and that we knew we had to add more time, and we still didn't have enough time, so we'll have to have you back soon because you really bring a higher level of methodology and skill and scientific thinking to this issue. It's so critical. So I want to encourage people to look up some of the articles that Dr. Jones mentioned and ask the questions that you have to ask. Ask the questions in your science work, and especially if you're an academic. Ask the questions, and then you'll get different methods and different answers. So I look forward to having you back. Maybe we should do it, after July or something like that. I want to remind people we got the 150th anniversary of APHA coming up this fall. So we'll be doing some shows to highlight that and getting people ready for that. So again, thank you so much, my sister, for coming on. It was really a pleasure.
Oh, well,
Dr.
thank
Jones,
you. Yes.
Go ahead. What would you like to end with?
I just want to say that I have been ending a lot of things. And even when I'm doing commencement addresses, I talk about my 4 BCs, the letter B, the letter C, my 4 BCs, which are habits of mind for social justice warriors. They are: be courageous, be curious, be collective, and build community. So when I say be courageous, I mean speak your truth, be unafraid of controversy, embrace challenge, know that for all of us, the edge of our comfort is our growing edge. When I say be curious, I mean ask why, like you said, Linda, and ask why again. And why again? And when you ask these serial whys, you will go beyond superficial explanations to identify root causes. Also, when you're curious, you need to read widely and read history. You need to learn more than one language and travel as widely as you can across town and around the world. When I say be collective, it's really care about the whole. That's it. So share your energy, your insights, your time, your material stuff with others, and especially organize, because collective action is power. And finally, the 4th BC, build community, which means be interested in the stories of others and then believe the stories of others without requiring cell phone video documentation or body cam footage or whatever it might be, and then join in the stories of others. So talk to strangers, create opportunities to burst through your own bubble and for other create institutional opportunities for people to burst through their bubbles of experience, to experience our common humanity in very different circumstances, just on the other side of town. Really, it's to go across town and stay a while, speak up and act on behalf of others, and go across town and stay a while.
I think this is the first time I'm speechless and don't have anything to say at the end. Only thing I want to say, of course, thanks for coming on, Dr. Jones. Everything in public health is every third Thursday. And the thing I would close with is I echo everything both these young ladies said. It's just that I would say to Black men, let's stand up and be more protectors in our community. Let's be more protectors of our Black women and Black children. Let's just try to be better men. You know, that's the best I could say tonight. And again, thanks for coming out. And the main thing, thank you, Dre. We couldn't do it without you. So thanks, Dre. And see you guys next month.
Thank you. Bye-bye.